Ready? Good evening, all. Department of Anesthesia, Perioperative Medicine and Critical Care, AIG Hospital, Gachibowli welcomes you all to the 6th webinar from our department. And we have dedicated this webinar on the cancer pain management, considering that today is the World Cancer Day. It's a fantastic platform because we are privileged to have a great faculty with a lot of experience in cancer pain management from across the country and internationally. Last couple of decades, we have seen resurgence of or flooding of literature with cancer pain management. A lot of controversies on general anesthesia versus plus or minus regional on cancer recurrence and metastasis. We'll be addressing these controversies as well. But yes, there's a lot of role on regional anesthesia and blocks in cancer pain management, and we have faculty of repute today to address this controversies and consensus on pain management in cancer. It's my privilege to introduce my co-host, Dr. Lakshmi, who is a senior consultant, lead consultant in our department. She has done a master's in anesthesia from Massachusetts, followed by fellowship in cardiac anesthesia from Cleveland Clinic, and she's also certified TE, transcatheter echocardiographer. And I ask Dr. Lakshmi to start off today's webinar, please.
Thank you, Dr. Sunil, for the introduction. Good afternoon, all. And today, it's Feb 4th, is the World Cancer Day, which gives us an amazing opportunity for us to use this platform to discuss about and also to increase the awareness among the cancer patients and also among the colleagues of anesthesia. And cancer, as we all know, it's a critical human and health issue. And until we create a future without cancer, we being the pioneers in the pain management, I think we should have a goal and we should take that responsibility of making cancer patients' life much more comfortable as it can be. And with an increasing survival rate for oncology patients, even the prevalence of oncology pain is increasing. So the cancer pain can be acute or chronic. So we're going to discuss today both in aspects of acute and chronic and the modalities that are involved in treating the pain and also the assessment and diagnosis of the pain. And when it comes to acute pain syndromes, it can be due to iatrogenic or it can be due to disease related. And the iatrogenic again can be due to diagnostic test related and also can be due to the treatment related, which can be chemo or radiation. And the disease related can be due to visceral pain due to obstruction or perforation, or the bone pain due to pathological fractures, and also if at all there is any tumor hemorrhage, they can have pain. So here the main aspect of treating these acute pain syndromes is the initial assessment and also coming to a conclusion, coming to a diagnosis of where the etiology of the pain is very, very important. Here comes our first guest lecturer, Dr. Bharat Patodia. He is associated with AIG Hospitals, Gachibowli, and he did his MD Internal Medicine in Bharati Vidyapeeth, Pune, and also he did his DNB Medical Oncology in Hinduja Hospital, Mumbai. So he has a lot of publications and also a lot of experience in the oncology field, and he's the kind of person who believes that, life, serving life in all its forms, and also he believes that there is a solution for every existing problem, which makes him apt for being in the field he is. And so it's a privilege to invite Mr. Bharat Patodia for our first guest lecture on clinical assessment and diagnosis of acute pain syndromes. Over to you, Dr. Bharat.
So, Namaskar. Thank you very much for this opportunity. All my viewers who are viewing our program, thank you very much for your audience. I'm a medical oncologist, only cancer patients, and trust me, all cancer patients are symptomatic. If not on presentation, then eventually, either because of the disease or because of my treatment. So the question comes, how to diagnose acute cancer pain? In these acute cancer situations, when patient was asymptomatic or minimally symptomatic and patient develops symptom, things are pretty much easy. Chronic pain syndromes, which also happens in cancer, is somewhat more dicey. Now, what is special about cancer pain? The first thing is it is multifactorial. When you compare cancer pain towards other type of pain like arthritis, like trauma or something, there is an injury, there is some event, there is one factor which is causing the pain. While in the cancer, it is multifactorial. Majority, more than 2/3 of the patient's pain is attributed to multiple factors: disease, treatment, something else, psychosocial reasons. So, and sometimes or many a times non-cancer related causes are also possible. These pain has physical impact as well as functional impact, and should be included in the assessment of the pain, which ranges from emotional aspects, affect the moods and the psychic, sometimes spiritual also. I see a lot of patients, or only patients for cancer, I see their spiritual journey also. Many patients who trust God become atheist and vice versa. Just pain addressal will be inadequate. Anti-cancer treatment also help. So compared to other situations where it's just chronic pain or some pain, you treat the pain, patient body heals itself. Cancer pain is not like that. You have to have a anti-cancer treatment also for better response to treatment, pain relief. Now, what to assess? In addition to our usual medical information taking, history taking, like what are the characteristics of the pain, location, frequency, what are the relieving and aggravating factors, what is the radiation, does it neuropathic or not. Something extra about cancer pain is what is the response to the previous treatment, including drug history, what patient has taken, because it has multiple drug interactions. There are ceiling effects of pain, drugs, also through breakthrough pain. What has failed in oncology has to be changed, whether it is the chemotherapy or it is pain control. So it's important aspect. Now comes the severity as assessment. There are multiple scales. One of my last slides are about multiple scales possible, but practically speaking, what is most practical in day-to-day clinical practice is either it is visual analog score from 0 to 10 for people who are literate, understand what is this type of scale. 0 is no pain and 10 is life-threatening pain. Or for people who are not so literate or not able to respond well, then subjective from no pain to mild, moderate, severe pain. So these are the two scales which is most commonly used, though there are multitude of scales available. I will be covering the few of the last slides. Now, diagnosis of acute cancer syndrome. As I mentioned, acute cancer syndrome is cancer pain syndromes are somewhat easier because patient was asymptomatic, present suddenly with some pain, deterioration in general condition, may or may not be. So, but if it is not so immediate, subacute or somewhat chronic, then the high sensitivity and high index of suspicion is required, because especially in India, there is a cultural limitation of reporting pain. People consider pain as an integral part of cancer, sometimes cancer treatment also. So they have this notion that I am receiving cancer treatment, I am bound to have pain. They don't report it well, which reduces the quality of life. History taking remains a key, the most important key for etiological pointers of its multifactorial background. I'll cover how. Radiological investigations are also important as far as cancer pain is associated, because we have to evaluate whether the organic reason or not. If there is, we have to address it. And don't neglect the lab aspect. So blood test, blood investigations, routine investigations, CBC, RFT, LFT plays its own role. I will be covering in next few slides. Now, by default, mostly it is the tumor which causes the pain. And trust me, except the actual CNS parenchyma, all tissue in the body can become symptomatic with tumor. So tumor infiltrate, they have sensory nerve endings, and it can cause pain. Even CNS tumor, though CNS parenchyma is not pain sensitive, but the meninges are pain sensitive, so ultimately can cause pain. So tumor causing pain could be visceral pain, it could be neuropathic depending on the location, leptomeningeal spread, then it is headache, mononeuropathy or multineuropathy, plexopathy because of the tumor deposits, for example axillary deposit or some nerve compression, which could be somatic nerves also. Rarely, paraneoplastics are kind of fascinating, but trust me, it is rare. often they manifest itself at multi-system levels. So if a paraneoplastic syndromes are present, they're usually having clubbing, they are associated with polyneuropathies, they are associated with skin disorders, sometimes CNS manifestations or endocrinal manifestations also. So these are the reasons tumor causing the pain. But that is not the only villain we are dealing with. Anti-cancer treatment also causes pain, and there is the role of history. And not only history, a basic knowledge about what treatment causes to the body is important for analysis of pain. For example, chemo or radiation both can cause mucositis, which could be associated with neutropenia, myelosuppression, or just because of direct injury to the mucosa. Many chemotherapy agents cause that. Radiation, almost every patient who receive a head and neck radiation develop mucositis. Neuropathies, patient has received certain chemotherapy agents, for example taxanes, paclitaxel, docetaxels. They can cause painful neuropathy and can present as pain. The pain physician might be scratching their head why the patient is having pain. They are giving lot of painkillers, but they are not responding because this is because of the direct trauma to nerves which conducts pain in the periphery by paclitaxels and docetaxels. Platins also causes neuropathy, but kind of different. It causes tingling, more of tingling, positive symptoms. Vinca alkaloid like vincristine, vinblastine cause jaw pain. So if you don't suspect these chemotoxicities, you may not able to address the pain properly. So the history, somewhat knowledge about chemotherapy and what side effects they cause in terms of pain is an important aspect of pain assessment in cancer. Going forward, there are a lot of drugs which causes arthritis. For example, taxanes. So we call this pseudorheumatism. Why pseudo? Taxanes must be accompanied by steroids before giving taxanes and even after 2 to 3 days after giving taxanes. But for any reason patient doesn't take the steroids, it is not given, it is omitted because of diabetes or any reason, patient develop joint pains, and it can cause arthritic like symptoms. Similar situation can happen with aromatase inhibitors and GCSF, which is integral part of most of the chemotherapy drugs. So again, the knowledge of chemotherapy and the anti-cancer treatment is important. Plexopathy, lot of breast cancer patients receive radiation as a part of their treatment. Post radiation they develop plexopathies because of radiation induced neuritis. Not only breast cancer, but if pelvic irradiation is there or abdominal irradiation is there for any reason. Enteritis or proctitis is again more associated with radiation, can cause refractory pain or refractory symptoms. Coming to the lab investigations, platins, all platins, cisplatin, carboplatin, oxaliplatin in varied intensity can cause Fanconi-like syndrome. So there is a loss of calcium, sodium, magnesium, and because of these loss of electrolytes, patient can develop symptoms like calcium loss can cause bilateral symmetrical muscle pain or joint pain. Sodium can cause headaches. So for example, endoxan or cisplatin, we ask patient to take a lot of sodium in their diet, a lot of salt in their diet, because if they don't do so, they can cause loss of sodium, ultimately causing headaches. Osteoporosis and associated pain, any of the hormonal agent which we use in prostate, breast and ovaries can cause osteoporosis associated pain. So my point of this slide is to be aware of what is happening with cancer patient. Cancer patient is getting hit from various reasons, from cancer, from drug, and lot of psych also. So all these things can contribute different type of pain. The full picture is more important. Not only medical oncology, even the surgical oncological or surgical treatment can cause pain. For example, any injury in the body, there is a recovery of the nerves. So surgery, post-surgery, there is a recovery, neuropathic pain can develop depending on which area. So for example, a lot of women after axillary dissection complained of radiating pain. It can also cause change in physiology. For example, somebody has undergone some GI malignancy resections that can cause a lot of bloating associated with pain, distension, symptoms. Sarcomas, peripheral sarcomas, they undergo resections, amputations, which can ultimately cause phantom pain, neuropathic pains or stump pains. And if we don't understand the exact pathophysiology, we may deal with a refractory case. We can deem it refractory. Now, anti-cancer treatment is not always bad. It is also good in way that giving anti-cancer treatment appropriately can help in these pain. For example, radiotherapy, radiation to bone metastasis. So any solid malignancies which is spread to the bone, about to go for a cortical breach or having a little bit of cortical breach, we can give radiation high dose to only of that area, reduce the cell burden, cancer cell burden, and can actually give pain relief as early as within a week. So in that situation, instead of keep on increasing the opioids, instead of keep on increasing painkillers, radiation one dose, symptom free. Again, if the organic reason like intestinal obstruction or nerve compression is there anywhere, then surgical decompression is required. Bisphosphonate can help to a certain extent in reduction of skeletal related event, that is fractures. Exactly pain relief, no, they don't help in the pain relief, but reduces the chances of fractures. There are a lot of adjunct medications which we use, like tricyclic antidepressant, duloxetine, steroids which reduces the inflammation, anticholinergic if it's somebody is having subacute intestinal obstruction and associated with lot of secretions, and sometimes we also use ketamine. I'm pretty sure my colleagues are going to cover those things in detail, so I'm not going in that. Coming to the assessment, now this scales suggest long list of lot of pain scales. So most commonly used numerical rating pain scales, Wong-Bock, or people who are not able to communicate like children or dementia or Alzheimer's patient with cancer can use these cries and comfort scale. Otherwise, brief pain inventory is also something very useful. Practically, no, practically we don't use it. Assessment also depend on the response of treatment. So what treatment you have given and how much patient has responded, that also determine what treatment to be given next. Also, assessment must include soft assessment, which include family's perspective, patient perspective, impact of pain on the lifestyle also. So which is not limited to just the physical body, but psych, emotional, affect, and spiritual part also. It is little bit affected by cultural difference and the expense the patient is bearing. Now the few last take home points which I want to convey to my audiences are: high index of suspicion is important. Sometimes patient don't report. Gather enough information on symptom, treatment received, what chemo or treatment, surgery, radiation has received, which area they have received, assess the severity. Why it is important? A cancer patient will never become zero symptoms. He will always have some sort of symptoms. So we should treat a patient when a symptom, especially the pain, affects the quality of life, affect the functionality of the patient. If we try to make a patient zero pain, in my experience, we end up giving some side effect of the treatment. So opioids will cause drowsiness, constipation, hallucinations, or something else. So treat according to the severity. Something which is severe, affecting the quality of life, day-to-day daily activity, must get adequately prompt treatment. Why? Most of the cancer patients who are symptomatic are usually in the advanced stage. They don't have time to waste. Even one day wasted in a symptom is a long time of their remaining life which is wasted. So that is all from my side. Any questions? I'm open to that.
Thank you, Dr. Bharat, for a detailed presentation on assessment and diagnosis of acute pain cancer syndromes. So,
Yeah, we can have questions at the end.
Yes.
Or,
we'll have questions at the end.
Thank you. Thank you for the opportunity. Thank you for the audience.
please take a seat.
So once the assessment and the diagnosis of acute pain syndromes is done, the treatment part begins. I mean, the treatment, the newer modalities that are existent to help the cancer survival patients. So in this day and world where we are trying to minimize the opioid crisis, the nerve blocks play a very pivotal role in managing this cancer pain. So the nerve blocks, when we do it, they offer immediate pain relief, and used to be limited only to the orthopedic procedures, but now extended to other specialties, almost gastro, urology, bariatric, all entire multi-speciality procedures, now blocks have been extended, and previously used to be limited only to the inpatients because of the follow-up plan and possible complications that's associated with it. But now, since the ultrasound came into the view, into the picture, then the amount of complications has come down, so it got extended to ambulatory surgical care patients also, who've been discharging on the same day, going home with the elastomeric pumps for effective pain control, but with a follow-up plan, like somebody to follow up and make sure that they're doing okay and dealing with the complications. So in that aspect, I take the honor to invite Dr. Santosh, who is the Director of Division of Endoscopic Division at AIG Hospitals, Gachibowli, and he's been one of the most experienced anesthesiologists in the endoscopy division, both therapeutic and diagnostic at AIG Hospitals since its inception. And also where at AIG, as we all know, the highest number of cases are being done in the endoscopic unit, both newer modalities, therapeutic and diagnostic, in the entire Southeast Asia. And I'd like to take this honor to have Dr. Santosh start on new nerve blocks in acute pain management.
Thank you, Lakshmi, for the introduction. Today I'll be talking on blocks predominantly in cancer pain. Pain is experienced in more than 90% of the cancer patients. 50% of patients, it's moderately to severe. Most of the patients, the acute pain, by the time they reach us, the pain physicians, the acute predominantly managed by the oncologists, like what Bharat had said. So the opioids are already would have been started, or the dependence will be going on by the time they reach us. So I know the word acute. Cancer pain, 50% are patients is moderately pain, most of them they suffer with. The cancer pain causes a reduced ability to tolerate the treatment. So that is the reason why you have, and then that leads to depression, and the quality of life also is affected in these patients. The pain management, usually most of the cancers, it revolves around the opioids. That's at least 70% of the patients respond to opioids. But if they're not responding to opioids, that's when the pain physicians or the oncologists think about interventions. That's when they refer to them, for the patients to us. Intervention techniques are necessary in at least 25 to 30% of the patients in whom pain is refractory to opioids. Intervention procedures early in the course of cancer pain definitely helps prevent suffering and morbidity rather than quite late during the disease process. All neurolytic techniques result in valerian degenerations to some degree. That is, degeneration of the nerve axon distal to the destructive lesion. But if the axonema is intact, nerve regeneration occurs, leading to a return of sensation. That's when the patients think that the blocks have failed. But it's not so, but most of them who live through the disease, they do come back, so we can repeat the block. I'll be talking more on GA related blocks because that's what I've been involved with all these decades. So the GA related blocks are splanchnic nerve block, celiac plexus block, superior hypogastric plexus block, and the ganglion of impaired block. The splanchnic nerve block, we see in arterial embolization liver, that again post-arterial, they come with acute pain. There also we have to take a call about this block. Abdominal angina, visceral arterial insufficiency also is an acute condition. They come in, we do a block on an emergency basis. Retroperitoneal malignancies, of course, you do have time to plan for your blocks. Superior hyperplexus block is another visceral pain from malignancies of the ovaries, uterus, anus, urinary bladder, rectum, and prostate. And this is another painful condition which may be precipitated with some pain there. If they are constipated, they come as an emergency, like perineal pain for rectal or anal cancers, or metastatic perineal lesions. See, the commonest interventional procedure preferred for cancer pain is a celiac plexus block, which covers most of the abdominal organs, the GI organs, like the pancreas, hepatobiliary system, small intestine, stomach, spleen, ascending colon, transverse colon, and the adrenal glands. A few words about the celiac plexus. It's a dense network of interconnecting fibers and ganglia, which number from 2 to 5, which are located caudal to the diaphragm, which is anticrural in location and surrounds the origin of the celiac artery. That's how it gets its name. But it is predominantly around the aorta at the level of the celiac artery. And it corresponds to the level of, L1 vertebra, but it may extend from T12 to L2. The network of sympathetic ganglia transmitting nociceptive signals, as I mentioned, from pancreas, hepatobiliary system, small intestines, stomach, and the transverse colon. The mechanism of pain in the pancreatic malignancies is basically due to the ductal hypertension because of the ductal obstruction, and the high pancreatic tissue pressure may lead to a compartment syndrome type of picture. This also sometimes can come as acute pain. The fibrotic encasement of the sensory nerves also is a cause. And pancreatic neuropathy, there is an increased intrapancreatic sensory nerves and inflammatory injury to the nerve sheaths. So the celiac plexus neurolysis is the procedure necessary for these pains. So there are different approaches for a celiac plexus neurolysis. The age-old technique where most of the pain physicians follow is a percutaneous fluoro-guided approach, which has got a retrocrural. Some do it retrocrural or anticrural or transaortic. Transaortic, the results are good, but it can cause problems. Depends on the patient. Percutaneous CT guided transcrural approach, US guided approach is fast catching up. Anterior abdominal approaches will be CT guided or ultrasound guided. And intraoperative approaches, some people who are undergoing surgery for pancreatic, at the same time the nerves can be identified, the plexus, and they can be blocked intraoperatively. Basic contraindications are severe local or systemic infections, uncorrectable coagulopathies, then we can have a lot of hematomas and lead for infections again. And people allergic to contrast dye also, it's better to avoid. Neurological deficits are relatively, suppose the pain is very severe, it's always better to go ahead with the neurolysis to improve the quality of life. Patients with bowel obstruction also, it's a relative contraindication, because once there is a sympathetic block, the parasympathetic overactivity can lead to a perforation of the bowel. And abdominal aorta aneurysm also is a relative contraindication. You can see, depending on the location of the aneurysm, we can plan for your block. The percutaneous fluoro-guided neurolysis is preferably done pre-procedurally. We hydrate the patient by giving 500 to 1 liter of saline depending on his requirement, because post-procedure the chance of hypotension is high, so it's always better to preload the patient. Patient always is in a prone position most of the time, unless he cannot sleep in a prone position. We have a pillow below his abdomen, and we try to do without sedation, because so that we can keep getting a feedback from the patient following the diagnostic block. We give an antibiotic prophylaxis, and we preferably do a double needle technique where we do take two 22 gauge needles with a 13 centimeter length stellated needles. We start by marking the process of the D12 spinous process, which corresponds to the body of the L1 vertebra. The two entry points are taken about 2 to 2.5 inches apart from the spinous process. We infiltrate there, and then we go with the needles at a 45-degree angle, hit the body of the vertebra, we draw it a little, and then advance it so that it walks off the vertebra, advance it about 2 to 3 centimeters beyond the vertebra, aspirate and check whether you are intravascular or in any organ. Suppose your needle has waved out of the course, and then inject contrast to be absolutely sure where you are. Then you give a diagnostic block with about 5 ml of lidocaine on either side and ask the patient whether he is relieved of his pain. If he is relieved of his pain, that gives an indication you are on target, and you can inject your chemical agent of absolute alcohol, about 10 ml on either side. Some people inject even more, but I feel 10 ml is good enough. The side effects and complications, what we usually see are orthostatic hypotension. That happens due to the sudden dilatation of the splanchnic circulation with the sympathetic block. So since if you're already hydrated, it's good enough, there should not be a problem. Retrosternal bleeds can happen because when you're advancing your needle, the patient moves around, you can hit a few vessels, especially in malignancies. If tumors are vascular, that's when you can have problem. Close black diarrhea is seen in about 50% of the patients. That is because of the sympathetic blockage. The parasympathetic overactivity leads to the diarrhea. They spontaneously settle down in a day or two, but in case they don't, then you may have to medicate them. Trauma to the spinal cord or the existing nerve roots is quite rare unless he's a beginner. Paraplegia also is very rare. Trauma to the kidneys and ureters are also very rare. They have been reported. Trauma to the thoracic duct also is a possibility leading to chylothorax. So the other way to do a celiac plexus neurolysis is by US. This is how it looks. When you visualize through a US, the celiac plexus, they go transgastric and the approach is anterior. The posterior, in PER-CUTANEOUS, we go a posterior approach, while in US guided, it's an anterior approach because it's transgastric. So we have to decide which technique is better, the PER-CUTANEOUS or the US guided. So we had done a randomized clinical trial a few years back comparing the fluoroscopy guided PER-CUTANEOUS technique versus the endoscopic ultrasound guided technique for a celiac plexus block for treatment of chronic pancreatitis. Even though it was chronic pancreatitis, we tried in malignancies also. We found that the US guided, the pain score was much better compared to the PER-CUTANEOUS. US, they had the advantage of being done under vision. PER-CUTANEOUS is always a blind procedure. You only approximate where you are and then do it at fluoroscopic guidance. But what I found was when we did for malignancies, the PER-CUTANEOUS was not as bad as it was for the benign condition like chronic pancreatitis. Maybe the steroid wasn't doing that good a job as the alcohol was. Coming to the US CPN techniques, there are again different ways of doing it in US guided. It is a unilateral or a bilateral CPN technique. The other technique is they can directly visualize the ganglia and do a neurolysis, or it's a broad plexus neurolysis. There is a unilateral or a bilateral. In a bilateral, they inject on 3 ml saline on either side of the celiac artery. After visualizing it, they aspirate and inject lidocaine and bupivacaine to cover for the pain which they get when they inject the neurolytic agent. 10 ml on either side of the artery is injected. Then they flush the needle with saline before they get out. Central versus two-sided neurolysis, there were studies conducted which showed that bilateral injection, their pain relief was about 85% compared to a unilateral injection. So there are different various studies of central versus bilateral injection, but ultimately the verdict was bilateral injections were definitely superior. There was in some studies there was no difference. So the question is which US CPN technique is more effective, bilateral or central? So bilateral with definitely was superior, but with the needle advancement caudally beyond the level of the celiac is superior. But technically, unless they are well trained, you may not be able to achieve this. So the operator comfort should justify the central injection as an acceptor. If he's a beginner, I think it's better we go with the central injection. Maybe the result may be a little compromise. The other option was the broad plexus block. Suppose the tumor was encasing the celiac plexus and you are not able to access the exact near the celiac artery, so then they went in for a broad plexus block. where you level up the superior mesenteric, you give superior, middle and inferior. So that covers all the three. So this again, the studies were not randomized. The low success rate of bilateral CPN was another indication for them to go for a broad plexus block. And deeper injection had to be done with more side effects. So should the celiac ganglion be targeted during use-guided neurolysis? Sometimes then the statement is there is no clear evidence that celiac ganglion is more superior to bilateral or broad plexus CPN. Therefore, because the ganglion, what I had been discussing with some of the endocrinologists was some of the initially earlier what they thought was a ganglion later on turned out to be nodes. So there is always a confusion. So what when they think, because some of the endocrinologists they used to say when we hit the ganglion, patient almost jumped off the table, and that sort of statements they were giving. But later on they realized even the nodes look almost like ganglions. So that may not be an ideal way to do it. There are newer methods which are being tried out, like US guided celiac ganglion irradiation with iodine 125 seeds for pain control in pancreatic carcinomas. This is still studies are going on. The other one is US guided radiofrequency ablation. It's a feasible technique and might represent a promising therapy for the future treatment of pancreatic cancer. These also still a lot of studies are going on. Nothing is real definite data is still not been documented. However, further studies are necessary to investigate further. The predictors of response for CPN for cancer of the pancreas, the greater the pain, better the relief. And the thing is, it should be performed early in the course of the disease. The problem is the patient has to be referred to a pain physician. That's the message is, so that you catch the patient early, not after the whole area is infiltrated and then come back saying that the block was not effective. Absence of celiac plexus invasion by cancer is essential, and increase in the heart rate during CPN also gives an indication that your block was effective. So to conclude, the celiac plexus neurolysis US guided was superior to percutaneous radiological guided because that was definitely being done under vision. So we expect the results to be better with the US. The central and bilateral injection, of course, that is based, it's debatable because of the operator dependence was definitely there. Celiac ganglia neurolysis direct was not recommended because you are not sure whether you are really hitting the ganglia, and we need more randomized studies. These are team at AIG. Thank you.
Thank you. And I'm sure most of the audience who have been listening to us are clear about approach for celiac plexus neurolytic block in cancer pain management as well as chronic pancreatitis. Probably as and when the questions comes, we'll have the questions at the end. We'll have the next talk. There is a little shuffling of the talk because Dr. Raghu Thota has some other commitment. He'll be joining us soon. But meanwhile, I have requested Dr. Sandeep Kulkarni has agreed to prepone his talk. Dr. Sandeep Kulkarni, as you know, he needs no introduction. His CV runs into several pages. Just a brief a snapshot view. He did his MBBS and MD from BJ Medical College, Pune. Subsequently, he went to UK, did his CCST, like specialist training in anesthesia, FRCA from UK. He worked there as a consultant in Chelsea, Westminster, Milton Keynes, and several other hospitals. Subsequently, he went to KK Hospital, Women's Hospital in at Singapore. He was working with one of the leading consultant, Dr. Alexia, who has several inventions at his place. He did his fellowship in OB anesthesia, followed by fellowship in pain management, and subsequently was in charge of pain clinic at Singapore. And from there, he moved to Qatar, and he was in charge of the pain clinic at Qatar as well. And now currently he is in UK again as a locum consultant. So Dr. Sandeep Kulkarni is again has a lot of experience in pain, several publications in pain management. He has also a membership of several pain societies like British Pain Society and several other societies. He'll be talking to us, throwing light on chronic pain management and palliative pain management. Over to you, Dr. Sandeep Kulkarni.
Thank you, Sunil. That's very nice of you and kind of you. Can you all see me?
Yeah, we can see you.
But I can't see you. I've got three confessions to make. The first and foremost, as being anesthetists, we always think about the worst. And in Pune, there is a tendency on Thursday, they switch the electricity off. So today being Wednesday, when they are, oh, today is Thursday actually, so might be, you may not be able to see me. I may vanish quickly. The second is that my Wi-Fi, for some reason, Idea mobile data does not work here. And the third thing is that, Sunil, thanks a lot that you gave me opportunity. Dr. Patodia is from Pune, opening batsman. I'm from Pune as well. So thanks for giving Pune its opportunity. I'm going to talk about the chronic and palliative pain management in cancer patients. My talk is going to be very much hands-on. I will not be pouring lots of data. I'll be talking literally what I do day to day. So I'm going to start with a real scenario, and Sunil may very well know this. This happened in 2016. There was a 20-year-old boy with rhabdomyosarcoma. He was admitted to hospital in Hyderabad, I think Sunil's hospital, for pain management. According to the oncologist, the patient was in the terminal stage, unfortunately, and the life expectancy was merely a few days. The pain medications were not proving to be effective. The patient came from a very much cultured, literate, well-to-do family who had a good understanding of the situation. They had a full team, oncologists, neurologists, psychologists, pain specialists, physiotherapists, everyone was involved, but ultimately the patient who was having his last few days on the planet Earth was suffering in pain. I mean, me and Sunil have been together for quite some time. Got a call from Sunil. It was a different talk. It was a friendly talk, but he just mentioned about this. And we basically tried to do something which gave a great relief to the patient and mainly the patient's family as well. And they were very grateful to Sunil. I think Sunil knows this, what I'm talking about. Am I correct, Sunil?
Yeah, I remember that.
So, well, as we all know that it's a big challenge to control the cancer pain in the patients who are really suffering, and especially the terminally ill. I mean, we have had some previous talks where they have mentioned the incidence of chronic pain or in the chronic pain patients or in terminal patients. At some stage during the cancer survival, the patient will have some kind of pain, and it's not easy at times to control it, and that can be a challenge. There can be three types of pains, most common being the bone pain. It comes because of the metastases of the bone, or as Dr. Patodia mentioned in his first talk, after the surgery, in the post-surgical incision, sometimes it gets infiltrated, you get pain, and it's quite bad. Second can be because of the visceral pain, distension, stretching, or compression of the viscera. And the third most common is infiltration of the hollow viscus. One must not forget about the neuropathic component in the pain. Nearly 1 in 3 will have neuropathic pain. Let's talk about the principles of pain management. One should not forget that it has to be a multidisciplinary approach. The best team would be the team consisting of oncologists, the pain physicians, neurologists, psychiatrists, psychologists, spiritual counselor. One may actually start saying what's the role about your spiritual counselor, but when you actually start working in palliative care settings, you will really understand. I myself have to blame myself as well, because when I did my pain fellowship a long time ago, that was in 2002 in St. Bart's and Whips Cross Hospital, we used to get posted to a palliative care setting. And I did come across a spiritual counselor there. And being really my first few probably months in the pain fellowship, I actually started wondering what is he doing. And later on, when I found out that the patient had literally turned a corner, and I started believing spiritual counselor is really, really important. I'm not sure whether we have that as a team member in most of the parts of the world, but that is something which I would strongly consider. We don't understand the importance of occupational therapists. But,
Sorry to interrupt you,
these are the
Sandeep.
people-
Do you have PowerPoint presentation or just talking impromptu? You have, because we are not able to see your slides.
Okay, so actually I tried to share my screen, Sunil. I'm not sure whether I have been able to do that. What about now?
Yeah.
You
Yes,
can?
we can see the slides now. Yeah. Thank you.
Right. So the most important principle that we should have the multidisciplinary team. As one of the speakers mentioned, there can be more than one pains. At least 80% will have two pains. One has to clearly identify the pain because visceral pain, somatic pain, and neuropathic pain don't respond to single medication. There can be an overlap, so we have to really look into it and identify them clearly. When we start any medication, we need to have a regular review, especially in the cancer patients, because sometimes they get so used to it. I mean, the tolerance, what we heard from our second MBBS term, really comes into place is in the cancer settings, because they sometimes have loads and loads of opioids or some medications which they become tolerant to. As we increase the dose, sometimes the side effects set in, and the golden rule of pharmacology is that if the side effects outweigh the benefit, you have to stop them. Same goes true here. We all know the WHO pain ladder. Step one is the baseline painkillers like pain medications like paracetamol and NSAIDs, followed by adjuvants, weak opioids like codeine, dihydrocodeine, strong opioids, morphine, and analogs. I must say that there is no scientific evidence to support that we should be sticking to WHO pain ladder when it comes to cancer pain. We really can twist and turn around, and we can even start on a moderately weak opioid or strong opioid or even tramadol and just start adding medications after that. We don't have to start on the baseline of the WHO pain ladder. That is something which I have always practiced. In terms of medication, what is in a repertoire? Well, traditional NSAIDs, COX-2 inhibitors, tricyclic antidepressants, anticonvulsants, SSRIs, SNRIs. I mean, you know what SSRIs like escitalopram, fluoxetine, paroxetine. SNRIs like venlafaxine, duloxetine, tramadol. Sometimes we inject steroids and sometimes even give oral steroids to reduce the inflammation, and edema sometimes can be quite good in terms of pain relief. Opioids take the main bulk of the pain management when it comes to terminally ill patients. Ketamine and cannabinoids. None of the anesthetics require any introduction to ketamine. And cannabinoids, it's something which we should actually really look into. I'll just share a little note. Unfortunately, I lost my father-in-law last year during the biggest of the COVID situations. He succumbed to not COVID, he succumbed to a kind of cancer, multiple myeloma. We all know what that is. And I actually gave him cannabinoid. I mean, it's very much really available cannabinoid oil. And I actually gave him that. A confession. Coming to opioids, I mean, we start with codeine, morphine, diamorphine, hydromorphine, buprenorphine, fentanyl patches, OxyContin, and of course, we know that tramadol is not opioid, but it's quite commonly used. One must remember one thing, that when we start using any opioids, the commonest side effect being constipation, so one should not forget to give laxatives if required. What are the routes we use the opioids or any medications for that matter? The foremost route will be oral, always preferred use, or always preferred unless there is a contraindication, like patient can't swallow or he has some enteral problems, he can't absorb, then we go to the other routes. We have to titrate the dose according to response. We will never know on the very first day what is the best medication and best dose for any cancer patient, for that matter, any patient in chronic pain, but especially when you're talking about the cancer patients and terminally ill patients. We must remember the breakthrough pain relief, because always pain is in cycles. It goes in waxes and veins. And when you are doing the palliative care settings, or I mean, you're a part of that team, or you're doing chronic pain clinics and you're chronic pain consultants, you will know that one cannot get away without starting the breakthrough pain relief. Once we know the 24-hour requirement, we can always start with the slow release preparation. And the golden rule is any breakthrough pain relief is nothing but the 1/6 of the dose of the original one. The route which is very commonly used in palliative care settings, especially in England, is the subcutaneous route. It's obviously going to start, we are going to start it when you don't have oral route as a possibility. It's a very easy to start. Just, pinch your skin and start just insert a needle as a subcutaneous cannula and start on the syringe pump, either morphine or diamorphine. In US, they use hydromorphone. I have no knowledge about hydromorphone, never worked in US. The good thing about the syringe pumps is that you can have a very high amount of medication, very high quantity of medication in a very small syringe pump, like 10 or 20 ml. And they can run for practically a day or two. When you have started working in palliative care settings, you will know what I'm talking about. It reduces the workload on the staff, as well as it's very helpful for the patient. You get a sustained medication in your system, and the pain relief is probably a bit better. It's very easy to convert when you have an oral, when you know the oral dose of morphine. The diamorphine subcutaneous is 3:1. You have to have a breakthrough pain relief again, which will be 1/6 of the total dose in 24 hours. You need to change the site if you have any signs of sepsis, like erythema or tendency to have abscess formation. And theoretical, we really have not come across that coagulopathy can be a contraindication. It's really theoretical. Whenever one starts with the opioids, we should never forget antiemetics and laxatives, as I said before. The route is intravenous route, not very commonly used. If at all it is used, it should be in the HDU, especially for only palliative care settings who have got terminally ill patients and very the life expectancy within a few days. Transdermal patches, fentanyl and buprenorphine patches, are quite commonly used. The conversion is very straightforward. You just have to know the dose of your oral morphine and titrate, and just convert to the fentanyl patches. Having said that, one may not come to exact titrative dose because, for example, if you start with 50 micrograms, you may require 12.5 more. And certainly fentanyl patches do come in various dosing, including 12.5 microgram per hour, and they go up to even quite high doses like 200 micrograms. Coming to the fentanyl patches, which is again a mainstay in the chronic pain settings as well as in the palliative care settings, available in various doses from 12.5 to 75, and you can put as many as you want. Having said that, I have come across a few patients who were on massive dose of fentanyl patches along with the breakthrough medication, and I decided that enough is enough. I went for intervention. You can change the fentanyl patches theoretically every 72 hours, but in the palliative care settings, even at every 48 hours. You'll be surprised how much high dose of opioids the terminally ill patients they tolerate. I have come across patients who used to have something like industrial dose of morphine, like 600 milligrams, and they just keep on increasing the dose and dose and dose because they're just not getting pain relief. A slight increase, they may say a bit better, but at the same time, you're not going to keep on increasing the dose of morphine. If they're not helping, better to do something else, better try something else. There's something called as opioid rotation, which I'm going to talk very soon. The preparation of fentanyl is fentanyl lozenges, that is called as fentanyl lollipops. I used that for the first time ever in 2001 with Dr. Andrew Lawson, who was my boss in Chelsea, Westminster. Because you're giving a very high dose of fentanyl when you're using the fentanyl lollipops, it basically gets absorbed practically straight away. You have to just literally suck it. It's transbuccal. And sometimes patients can have the same side effects like intravenous fentanyl, like some people feel faint, some people have hypotension. It's better if you're going to start the lollipops, you start them in a setting which you are well versed with. You should not give more than 4 times in 24 hours for the lollipops. And usually lollipops are used only for breakthrough pain and not as a first-line treatment. If the side effects occur, obviously that should be removed. The lollipops are available in 200, 400 to 1600 microgram doses, quite easy to titrate. They don't last for long. They last for not more than half an hour to 45 minutes. Other medication which is quite commonly used is called as OxyContin, oxycodone, oxynorm. Fast release and slow release preparations is more potent than morphine. It's around 2 to 2.5 times more potent than morphine. And I did a study, not in pain, not in chronic pain settings. I did a study in anesthesia. Sorry. I did in anesthesia. I think at least my study showed that the side effect profile was a bit better than morphine, especially in terms of nausea and vomiting postoperatively. It has got some neuropathic component, so maybe a bit more helpful than morphine. If you have got something you got used to, if you have got something you have got used to, then you better do something which is going to offload that and give you the same effect as the first medication. That's exactly what the opioid rotation does. For example, if you have a patient on a large dose of morphine, then you stop morphine but give OxyContin. So what happens is at the receptor level, opioid feels that, well, it's getting some new medication also. It's the same opioid. It's like, I mean, having two different sweets. When we get used to one sweet, we like to stop it and give another one. Other important opioid in opioid rotation to remember is called as methadone. It has got NMDA antagonist properties. It's quite very well used in chronic pain settings, especially when you have an opioid addict, and there are lots of them in the Western countries. Worth a mention about tramadol, but at the same time, please remember something called as serotonergic syndrome. I had come across one patient while in Singapore who had serotonergic syndrome. Thankfully, I knew what it is and could act upon it straight away. There are lots of interactions with tramadol, especially escitalopram, SSRIs, SNRIs, and patients can have something like hyper adrenergic activity, and sometimes they have hypotension. They even can come across as a patient who have had a heart attack. Patients can complain of chest pain, they have shortness of breath. So it's something we should remember when you're starting anyone on tramadol, if they have got some other backup like escitalopram, SSRIs or SNRIs. Coming to nerve blocks, my previous speaker has talked a lot in depth about nerve blocks. I'm not going to talk a lot, but remember one thing, that nerve blocks are done not as a first line. They used to be done as a first line when I would say early 90s or late 90s. But with the advent of more and more medications, especially opioid medications, the nerve blocks do have a role, but they don't come as a first line. They do come as a probably second or third line when you don't have a good pain relief with the pain medications when you're giving them either orally, subcutaneously, intravenously. One nerve block I would like to mention here is when we use the nerve block, we use a phenol or absolute alcohol. Sometimes radiofrequency helps, especially in percutaneous cordotomy. That is something I wanted to talk about, percutaneous anterolateral cordotomy. The pain has to be unilateral. You go literally at the cervical level and you go at C1 and you literally pierce the cord and you burn the anterolateral spinal thymic tracts. The patients can have dramatic pain relief. Obviously, it is used only in the palliative care settings. The other techniques I'm not going to mention in detail. Previous speaker has already spoken about it. One of the mention, I completely agree with him, is that the celiac plexus block is the commonest one we use in the chronic pain settings, also in the palliative care settings. It's quite, well, I would not say it's easy, but it's relatively easy in chronic pain settings and in palliative care settings because of the mixture, what you get in the palliative care settings with the biochemistry. Contraindications of the nerve blocks, needless to say, the lack of patient consent. If the patient doesn't want it, I mean, you have to give him the full right not to have it. In summary, the chronic pain, the pain in the palliative care settings has to be managed by a holistic way. It has to be multidisciplinary. One most important thing is communication, not only between the physicians, but also with the patient and more importantly, patient's family. I have learned not only in chronic pain, but in anesthesia also, that it is the communication most of the times lands us in the problems. We should be very honest with the patient, and at the same time, we have to be realistic. If you know the patient, especially in the cancer pain settings or even in chronic pain settings, you kind of know patient family, you become part of that family. And if you have a good communication, you develop good rapport, and the results are much better. We all should have, the multidisciplinary team must have a common goal, and that has to be the patient first. There are no egos. The communication has to be very clear. We should use medications, injections appropriately, and one must remember the role of spiritual belief. So that's all I have to say. Thank you very much.
For sharing your knowledge and experience on this dais, on this excellent platform, World Cancer Day today. Thank you so much once again. And moving on to our next presentation, I mean, although many of the ERAS protocols minimize the opioid usage in cancer patients for pain control, still they have been part of the pain management, as Dr. Sandeep Kulkarni has mentioned about different types of opioids has been in use to manage the cancer pain. So in order to show some light on opioid crisis and also the newer modalities that we have to minimize the opioid usage and also to improve the cancer pain management, I would like to invite Dr. Sudhir Dara with the background of MD anesthesia. He's one of the senior chronic pain consultant and has been many national and international hospitals. He has been a visiting consultant and also has been a national and international faculty for many of the pain conferences. And also would like to proudly say that he's a founder and course director of Epic Pain Fellowship, and he successfully conducted almost 7 international cadaveric interventional pain workshops. So I would like to invite Dr. Sudhir Dara for the next presentation on opioid crisis and improving cancer pain management on the newer modalities existence of today. Over to you, Dr. Sudhir.
Thank you, Dr. Lakshmi. Thanks, Dr. Sunil Pandya, and also Dr. Santosh for inviting me for this webinar. I'm about to share my screen. Is it visible, sir?
The screen is still not visible, Sudhir. Yeah, we can see it now. Yeah.
You can see it. Yeah. Okay. So a lot has been till now discussed about the treatment, different treatment modalities of the cancer, and since almost 2 decades, what I have observed in Hyderabad and also in big cities of India, lots of new developments have been coming in terms of big infrastructure in treating cancer pains. Lots of big hospitals are coming up. Lots of modalities have been changing, robotic surgeries and all. But what really, as an anesthesiologist and also pain specialist, what we have observed is the symptom with which cancer patients suffer a lot, this pain, which is in some patients is very severe, is not properly treated in spite of having all these big centers of cancer. So somewhere we are missing the link, and somewhere we are unable to see the patients with cancer having at least 25 to 30% of the pain relief. So in this webinar, we would like to address few of the things which are a reason for this failure in the treatment for cancer patients, and what are the things which we can kind of come across to handle these things and give a better life, a short life of the cancer patients who are suffering with this. So this is my workplace EPON. It is in Hyderabad, where we have a complete comprehensive pain management modalities, and we have a good team of doctors working here. So introduction, this is all we know, the numbers. Lots of patients, they've been diagnosed as cancer and they die per year, which is around 8.5 millions. The 5-year survival rate is around 66%, the 10 years is around 40%. But when you see the amount of the pain, the amount of the burden with which cancer patients suffer with pain is around 30 to 40%. In this 30 to 40%, at least 15 to 20% of the patients, they have severe pain. So severe pain means they kind of forget the disease. forget about the disease, but the pain with which they suffer is quite immense. So this is the social burden of the cancer pain, and we as a medical doctors in fraternity should look into this. So the available modalities in relieving pain right now, there are very few, but the WHO has given a clear guidelines to how to step on with a lower potent drugs like non-opioids and go to weak opioids, add adjuvants and strong opioids. So this is good, and you can't strictly follow these things because sometimes patient will come with moderate to severe pain, then we have to jump to strong opioids. Sometimes very patients having a mild pain, you need not go for opioids just because the patient is having cancer. So that's how we need to modulate this treatment, which has been approved by the WHO. So generally, when we look into the cancer patients who come into the pain clinics, the initial cancer pain management is done with these drugs like NSAIDs, anti-neuropathic drugs, and Ultracet. Ultracet is the drug now which kind of every cancer patient, they come to the pain clinics. They say that no, Ultracet, they think that it's the best drug. It is the best drug available, particularly in India. They say that if I take Ultracet, I'll get a very good deal. But as you know, the composition of the Ultracet, it doesn't have a proper dose of paracetamol or doesn't have the tramadol in a proper composition. So tramadol will be 35.5 mg, and also the paracetamol is not more than 500 mg. So this is the best opioid, which a pseudo opioid we can call it as, which patients think that it can be reliever of their pain. And steroids also sometimes used, not knowing the real pathology. A lot of doctors, they use steroids also. But this is the initial pain management. When it goes beyond that, when you use these things and when the patient doesn't get a proper relief, then what will happen is we look into the final savior, which is the opioids. So opioids, morphine, they say it's a gold standard for cancer pain. So when we think that, when we say that opioids, particularly morphine, is the gold standard in cancer pain relief, then why are we worrying? Why all the patients are not getting proper relief? So is it a false notion that morphine is the gold standard, or these are not available? So this where comes the the point that opioid crisis, opioid is not available properly. Why it is not available? So opioids, as all of you know, they can cause addiction, and they can kind of take away the life of those patients who doesn't have pain. So that's why the government has called a war on drugs, and this war on drugs created lots of restrictive regulations so that the opioid is not being prescribed to the people who are in need. So that's the main thing where opioid crisis, which hinders our treatment towards the better pain relief in a cancer patient. And opiophobia, because as you know, I think in anesthesia, all of the Indian anesthesiologists, at least 60 to 70% of the anesthesiologists might not have seen a morphine tablet. Morphine injections we always see. Morphine tablet, they might not have seen it because it's not available. When it's not available, no one knows what happens if we prescribe morphine to any patient. That's where it is called as opiophobia. No patient doctors doesn't know where it is available and what will be done if you give it to the patients. And the lack of training also is a big issue, because if you don't know about the effects and side effects and complications and how to titrate the dose of these opioids, you always don't use it even though the opioids are available. So this is the basic problem within India. We don't know about the other countries. In India, opioid crisis, India is one of the major countries where they manufacture lots of opioid. Lots of crops are there, but they are being used in a different way. So that the government has given stringent restrictions not to freely available to the public and also to the doctors. So opiophobia is very, very the vital factor by which we are unable to dispense these drugs to the patients who are having severe pain. So poor assessment and inadequate knowledge among the clinicians about recognizing the pain of the cancer patient is one thing which leads to this opiophobia. Anxiety about the regulation. So no one wants to fall into these regulations, like you get the license, you maintain the list, you try to see that the patients are getting the proper doses, and something happens, they have to get back the drugs to again the center where he has taken. All these things they're a big headache. So that the anxiety is not being taken by the medical professionals concerned about the side effects. Side effects. We all know morphine or fentanyl, which are available as opioids in India. They've got lots of side effects. If you don't understand them, if you don't understand how to avoid them, no, then again you are a bit panic about using these opioids. So fear of patients becoming addicted and tolerant to analgesics is also another thing. We might think that we use morphine to the patient so that in future the patient might get addicted to the opioids which we prescribe. So that's again another point. So NDPS Act has come in 1985 and it is reformed in 2014. There are lots of things are there. Don't get confused, but they're simple only. But to maintain them, you need a team of doctors in your hospital. If you're clinic also, you can maintain, but only thing is you need to properly read them. So you have to properly maintain a list, properly maintain the strengths, properly maintain how to stock the drugs, and properly maintain all the records of the patients. And if you know, there is a punishment also. If you have more than the prescribed drug without license, if you possess that one, there can be imprisonment of 10 years to any doctor. So these are all the things which make them completely panicky and skeptical about the issue that shall we use or shall we possess the narcotic drugs or psychotropic substances which are there pretty much in India. So these are all the things which can lead to a kind of failure in treating the patients having cancer. So patients they don't want to use they don't want to express the pain, because when they express about the pain, they think that the doctor who is treating the cancer might think that might not look into the disease what the patient is having. So they don't want to report the pain to the doctors. They may think that it's basically he has got a cancer and it's an inevitable thing to bear the pain. So that's also one of the things. And maybe another thing is that they're worried about the tolerance to pain medication, so that after that there is no medication at all to get relieved of the pain. And if you think that addiction is also one of the issues which can relieve. So these are all the things which make us unable to treat the patients with the proper doses of opioids. So here, lots of things are there which already been discussed. There is a restrictive regulation of the controlled substances. Lots of doctors and big corporate hospitals and also health system, they think that cancer pain is not a big issue to be treated. They give a very low priority to this. So basically, one more important thing is if you ask any pharmacist or the medical shop, medical shops to stock this, the profit which they get from these drugs is very, very less. So if you get it in a bulk order, 10 mg morphine will cost only 1 rupee. So there is not much of the profit for these pharmaceutical guys to have an interest in keeping these medicines. This is also one of the things which is very, very, very important. So with this opioid crisis, because we already told that morphine is the gold standard for the treatment of cancer pain. So why can't we use it? Because of the unavailability, because of lack of knowledge, because of people, doctors, they don't know how to use it, and they don't want to involve in any other issues. So why availability of opioids? Why we are unable to make these patients not if is the reason. So apart from these newer modalities, how to overcome all these things is, so first we need to understand in treating cancer pain is the mechanism of the pain in the cancer. It can be pathological.
Like to see me go and come back for point.
Is it okay, sir? Any problem?
No, please carry on. Sorry.
No, I heard something. Okay, sir. So the mechanism of pain in cancer is very, very important. It can be pathological, like a tumor sitting on the nerve. Whether it's a soft tissue, whether it is a nerve tissue, whether it's a lumen, whether it's a viscera, that can give rise to. If you don't understand the mechanism, again the pain management will go wrong. And functional also, it can be bowel spasm, and some coincidental myofascial pain also can be there, which can be of importance to diagnose, to treat it properly. So you need to understand the different types of pains which can happen in cancer pain, which can be a soft tissue distortion or injury which is known as nociceptive. It can compress the nerve, which can be which is called as neuropathic pain, and very importantly, there can be a sympathetic pain also. You need to understand what are all the clinical features of identifying a sympathetic pain because of the it can because of the any damage or disease to the sympathetic nerve. If you don't understand these things and if you start doing any type of treatment, you will be end up in a failure. So management of cancer pain with the opioid crisis available in India. So what you need to do is it properly addressed with the available modalities right now, with all the drugs, with the opioids and other interventions? We need to look into this. So management of cancer pain, it starts with not only drugs and interventions, the non-physical and physical things are very, very important. They're very less in expenditure and they can be done by their kith and kin, and afterwards the drugs and also the interventions and alternative therapies. So drugs and interventions are the mainstay of the treatment options available right now in majority of hospitals. But you should not forget about other things also. Non-physical, as I told you, psychosocial evaluations, fear and anxieties are completely relieved when you explain the disease process, when you explain the treatment, and when you explain what is the patient to be expected and what is going to happen to the disease to the patient. So this psychosocial evaluation is always very, very important, which can take away lots of pain from the patient. So all these things should be explained in a non-physical way, and lack of awareness in dealing with the patient's pain will be medication available. If you don't know about the medication to be given to which type of pain, you will end up in problem. Proper usage is very, very important. Availability by the government, as I told you, the opioids and other things, and prevention of abuse is also very, very important. So analgesics, coming to analgesics, patient diagnosis is cancer, and don't think that these NSAIDs, muscle relaxants, antispasmodics, they don't work. They really work if it is properly indicated. Someone is having a severe colicky pain in the abdomen because of the obstruction. Antispasmodics, they work very well. Opioid will never work over there. Muscle relaxant, there is a stiff muscle which is causing severe back pain in a cancer patient having a prostate cancer. Muscle relaxant will help. And if there is an inflammation, NSAIDs will work wonder. So you need to understand and adjust your dosages and also the type of the drug to be given. Opioids, in India, the available are tramadol, tapentadol, morphine, and fentanyl. Fentanyl in form of patches and morphine in form of tablets and infusions. Tramadol, of course, tablets are there, which is a weak opioid. And don't forget to use the adjuvants, corticosteroids, whenever there is an inflammation, whenever there is a inflammation, the capsule on the liver, capsule on the sometimes some of the brain tumors, there is a inflammation around the dura, then the corticosteroids will run. Antidepressants, anti-epileptics, these are all the anti-neuropathic drugs. Whenever you see that patient's pain is of a neuropathic origin, these drugs will work wonders. So patient is neuropathic pain, antispasmodic, that won't work. If it is an neuropathic pain, you have to use the proper use of these NMDA receptor antagonists. These are not that available except vitamin. Lot of others are still trials. Muscle relaxants, of course, they are very, very important. WHO ladder is the one thing which you need to follow, because top and clarity. Having low grade pain, maybe visual and scale of 1 to 3, dose and low dose of and other things, and you need to add adjuvants whenever it is necessary. Try to address the complications and side effects. So with medical therapy, if there is any failure, what are all the reasons? So again, the same thing, knowledge about the pharmacology, precise drug for the precise condition. If it is a nociceptive, what is the drug to be used? In neuropathic, what precise dosage is also very, very important. Sometimes you might be seeing in the prescriptions tramadol 50 mg BD for a person who is weighing around 100 kgs. So that's a very underdose, and the timing is also not good. BD dose is not for the tramadol. Tramadol has to be given 3 times daily. So that's why you need to understand what is the dosage, or what are the pharmacokinetics and dynamics. Timing and follow-up is also very, very important. You start a treatment, treat it for 15 days, and ask the patient to come back again. You again take a analog scale and see how much of the pain relief. If the pain is getting controlled, you can again continue the dose. If the pain is not being relieved, you can increase the dosage or add some other drug. So this is how you need to understand. So this is what the injection 50 mg BD doesn't work for an adult, weighing around 70 to 80. Tablet morphine sulfate 10 mg TID we see lots of times in a cancer patient, because morphine has to be every 4th hourly, and in the night it's a double dose. So you need to understand these things, and then you can use a proper way of dealing with these patients. Opioids, morphine by mouth is the global strong opioid of choice for cancer pain. It's available 10, 20, 30, 12th hourly, and if it is a modified release, it's 24th hourly. Aqueous solutions are not available very frequently in India, but the oral tablets are very much available. Properly, getting proper link with us, you can always get it, even though you don't have a license. So there are dealers who have this license, and with your prescription, directly drugs to the patient. That can be done now. So guidelines of morphine, you all should be knowing that morphine has to be used every 4th hourly, and you have to start with the low dose. Increased low dose is nothing but 10 mg 4th hourly, and escalate it is to 30 to 50% every 2 to 3 days, depending on the pain relief. Night dose should be double because the patient sleeps there, and adjuvants to be continued. Laxative, as already told by Dr. Kulkarni, is mandatory. Endpoints are relief of pain or side effect. So there is no any ceiling dose for the morphine. So morphine can be given up to 300, 400 mg also if the patient is having pain. But if there is a relief of pain, there are side effects, you have to stop using the morphine. Renal failure, of course, we don't use. For that, we use some other drugs like fentanyl. Vomiting, diarrhea, ileostomy, these drugs will not be staying in the system. That's why these are not used properly. Persistent vomiting, per-rectal, suppository or subcutaneous can be done. Always, whenever you prescribe morphine for the first time, tell the patient and attendants, when the patient is very drowsy, like whenever he's made out, like you call him and tap him, if he gets up with an alertness, that means he's okay. But if he gets up with a drowsy feeling, like he's moving around his head and all, that means this patient is overdose. You need to understand that. So explain about the side effects. So fentanyl is a wonderful alternative to those patients who cannot take morphine. It is available in transdermal patches in India. Lollipop we have not seen, but it's been there since almost 10 years. I've been hearing this. I never saw a lollipop which is used for breakthrough pains. Transdermal patches are very much available. So unfortunately, what's happening is all these marketing guys, they transform this fentanyl citrate usage to the acute post-operative pain. So they go to the orthopedicians, they go to the surgeons, saying that the transdermal patches they work wonder for post-operative this one, because as a cancer patients, these are a bit expensive. They don't get that much of business. That's why they go to orthopedicians. Basically, transdermal patches are used only for the chronic pain. They're made for chronic pain. They're not made for acute pain. There can be problems with acute pain. Transdermal patches are very much available in India. There are 12.5, 50, 25, 75, and 125. So these are all the things to be used properly. There is no any other alternative, like patient is having some contraindications with morphine, fentanyl can be easily used. So contraindications to fentanyl patches, that you cannot use it in acute pain titration. Rapid titration of the medication is not, whenever there is not possible, you cannot do this because it can cause problems afterwards because of the accumulative, accumulation of the drugs in the body system, and can kick back again. Patient can go into respiratory distress and all. The advantages are less drowsy, less constipating, less nausea. Basically, you don't see all these things with the fentanyl patch. Only drowsiness to some extent, not properly used. It has to be changed every 72 hours. So you need to understand this. Alternative routes of analgesia, these are not practically possible. I never used dispersible tablets, sprinkling, sublingual things, suppositories. Transdermal patches are there. And one more thing I need to steps to this subcutaneous continuous infusions. It can be given at the home setting also. So you need to look into these things available. Neuropathic pain in cancer, as I already told you, try to see the disease progress and look into the PET scans and see if there is a nerve compression with the clinical symptoms. You can always try to identify whether it's a nerve compression or infiltration. Sometimes plexopathies, whenever there is breast irradiation, it can cause a brachial plexopathy, and you can have a cervical spinal cord compression also with the prostatic cancer or breast cancer metastasis. Surgical incision can cause pain, phantom limb pain, and also the treatments like chemotherapy can cause neuropathy, and radiation can cause fibrosis and plexopathy. The newer drugs in cancer pain management, COX-2 inhibitors, because of the complication side effects which we get with COX-1 inhibitors. Heterocoxib is very much available in India, and valdecoxib also. Properly using these drugs can avoid all the side effects of the COX-1 inhibitors. Trials, again, I'm telling you, lollipop fentanyl transfer is not available. I'm not saying, maybe a few of the doctors in India might be seeing it. Adjuncts for neuropathic pain, already discussed, NMDA receptor antagonists not available. Bisphosphonates for the bone cancer, bone pain because of the cancer is very, very much useful. And again, calcitonin is also for the bone pain. And also strontium 89, which is a radioisotope, is also can be used for. These are all advancements, but some of them are regularly available in India. We can always use them. So topical agents are very, very useful for the regional neuropathic pain, like in Europe, in a cancer patients having some a small area of severe neuropathic pain, like any lung cancer causing neuropathic pain on the chest. You can always put these lidocaine patches. Capsaicin is also available, but you get 8%, you get a lesser percentage also. It causes lots of burning pain. You apply it for 3 hours and take it out. It works for 3 months. It's not that it's available in India, but not used properly. So botulinum toxin is again a very good to relieve the myofascial pains or trigger points when patient complains after the surgery or without surgery. Also a regional pain where there is a severe trigger point, tender points. You can use a botulinum toxin, exactly injecting into the muscle can give rise to a good relief. Octreotide, when there is a bowel obstruction, there is a lots of secretions happening into the bowel that can be absorbed by giving the octreotide. That can be parallel, as already discussed. Just like tramadol, it's a centrally acting weak opioid. Cancer-induced bone pain is a major issue because the bone metastasis occurs and patients have pain. The pain is very intolerable, and there are lots of things coming up. Tanezumab is a monoclonal antibody which inhibits the neurotropin nerve growth factor, which works well with in cancer-induced bone pain. And bisphosphonates are very, very useful. These are majority of times, so these are used by medical oncologists. But as a pain specialist, also you should have an knowledge about how these are used. Breast cancer and multiple myeloma, where there is a bone pain, Pomidronate 90 mg every month IV for 2 years. Zoledronic acid has got its own dosage, like 4 mg IV once a year. Clodronate 16 mg. It's a oral tablet every day for 1 year. These things will really increase the comfort. The pain and pain source will come down in a reasonably good manner. Vertebroplasty, kyphoplasty is one more intervention which can be done when there is a vertebral fracture because of the metastasis into the bone. Just to mirror the metastasis and the fracture without causing pain is not an indication for vertebroplasty. So you need to have a pain at the fractured site. Then only you have to inject that bony cement through fluoroscopic guide, and see that particular fractured area is stabilized, and also the peripheral nerves, they get burned with the cement, and the pain will come down. You need to understand whether that vertebral fracture, which is there in the area, or extra, is causing pain, or something else is causing pain. If you don't analyze that, then you can go wrong, because it's a big procedure. So this is a vertebroplasty where you put your cannula into the fractured vertebra and you fill it with the cement there. So breakthrough cancer pains is always a big issue, because patient will be comfortable with morphine 20 mg 4th hourly and double the dose in the night. Suddenly something flares up. You need to tackle that, and you need to explain to the patient that you need to take immediate release morphine for this. So breakthrough cancer pain is again a very important thing which you should not forget to tell to the patients. So WHO recommendations for breakthrough pain is opioid morphine, immediate release formulation. A rescue dose 50 to 100% of the regular 4th hour dose must be considered. So that you need to calculate to the patient to take. So we have talked about the WHO ladder, where step 1, step 2, step 3. And if all these 3 exhausted, then what to do? So the step 4 is nothing but the intervention. So interventions are nothing but you directly go to the nerve or go to the tissue which is causing pain. So if it is a celiac plexus block, go to the celiac plexus block, block it, burn it. If it is a lower pelvic cancer, you go to ganglion, do radiofrequency patient, do chemical needles. So try to go there. The beauty of the intervention is it causes immediate pain relief. Even though if it's not long lasting, you can always give a good relief to the patient, so that interventions are kind of a boon for the patient. So whenever there is indicated. So this is one of the cases where patient has been operated. You can see the tracheostomy tube also on the radical neck dissection. I marked these points. So he was having a severe neck pain. So the one of the doctors, the doctors referred this patient to me, saying that some cervical plexus involvement, and also any neuropathic pain kind of things. It's nothing but a scar pain, scar neuropathy. This is the scar. The whole thing is scar. Just these are all the tender points which I marked. I did a small local anesthetic with a steroid injection, got more than 50% relief. So these are the trigger points which we see regularly in a surgically treated patients on the cancer. So we can see lots of prostatic cancer, breast cancers, metastasizing onto the spine and cause a radicular pain. If you see the MRI, if you see the CT scan also, you can see in those cases your transforaminal injections on that particular nerve, you need to identify which nerve is really having that pain. You can always give a good relief to these patients when if there is properly indicated. The caudal epidural steroids, where the sacral area and also the lumbar area is fully infiltrated with the metastasis. You can always do a caudal epidural, because the
Sorry to interrupt
higher
you.
above is not available.
So there, can we just, because we have one more webinar coming up.
It's done, sir. Almost 2 or 3 slides.
Sir, thank you,
Cervical epidurals, lumbar epidurals, intercostal nerve blocks. These are all the pictures. That's it. And also CELIAC plexus block, vastly it has been discussed. It can be done fluoroscopy, or it can be done CT guided also. Sympathetic blocks and ganglion part block for the pelvic cancer, pelvic pains, and also perineal pains. Superior hypogastric plexus block. All these things have been discussed. These are all the pictures which show how we have to do it. Radiofrequency ablations also are very important to permanently, kind of burn the nerves, intrathecal and epidural opioids. Intrathecal pumps are very good, and they are available very much in India. So these infusions you have to calculate and do. Intrathecal alcohol in later stages of malignancy, you can relieve these things. Spinal cord stimulators, of course, is a very expensive thing, but can be used. Emotional and spiritual support is very, very important in treating cancer pain. If you don't do that, whatever the medical treatment, intervention treatment, you're not going to get proper results. So take home message: avail the available treatment options, what are available in India, particularly the opioids. You have to be very, vigilant about that. Try them with the proper license. Educate yourself about the usage of opioids. Role of palliative care is very, very important. This is a multidisciplinary, and a constant communication between all the three: patient, caretaker, and caregiver is very, very important. Thank you, sir. Thanks a lot.
Thank you very much, Dr. Sudhir, for the very comprehensive overview on the newer modalities, and it was indeed a great talk. Sorry to interrupt, but as we have one more webinar coming up, so we had to interrupt you. And but anyway, very, very well taken talk. Please stay back. There are a few more questions already have come. We have the next topic and the last topic of the session today on acute pain management following surgery, which is passionate for most of the anesthesiologists, and we have none other than Dr. Raghu S. Tota, who is going to deliver this talk. He is a professor of anesthesia at Tata Memorial Cancer Hospital. He did his fellowship in pain management at Singapore, and subsequently he has been involved in several leading publications, and he's been involved as one of the first guidelines on pain management in the country. He is also on the editorial board member of Pain Physician Journal. He has received several awards like Navratna Award, Vaidya Ratna National Award. He was also awarded Guinness World Record certificate. He is the founder secretary of Society of Onco-Anesthesia and Perioperative Care India, and also executive member of AIDA, that is Airway Society, and coordinator for cancer pain management. More than 45 publications and several chapters in the textbooks in onco-anesthesia. His special areas of interest are intractable cancer pain, chronic pain, acute post-operative pain, onco-anesthesia, difficult area, and regional anesthesia. Over to you, Dr. Raghu, for the topic on acute post-operative pain management following cancer surgery. And we have requested him to confine to thorax and abdomen, because most of the time the acute pain management is very challenging in these cases. Over to you, Dr. Raghu. Can we have the audio on, please? You have to unmute
Okay.
yourself, Raghu.
All right, sorry. Am I
Yeah, you're audible now.
audible now?
Yeah, you're audible now. Yeah, thank you.
So I will be talking on post-operative pain management following cancer surgeries, and I have very lately seen this that I have to speak and restrict my talk on thoracic and abdominal. So coming to that, this is my team who we work at Tata Memorial Hospital. We are 4 people who do pain management, including myself, our head of the pain division, Dr. P.N. Jain, Dr. Aparna Chatterjee, and Dr. Sumitra Bakshi. So I have nothing to declare regarding this, and I have no conflicts of interests. So coming to what exactly is a perioperative or a post-operative or an acute post-operative pain management? So there are 2 aspects to it. It needs to be multimodal, and second, it needs to be individualized. So these are the 2 things we have to remember, and we have to work on it. So multimodal, and everyone knows that what exactly is multimodal. So it is not only one group of medications or one group of interventions. There are many group of pharmacological agents and many sort of interventions which we can use to give a comfortable environment and rehabilitation workout for this patient. Though we can't make the pain zero, even if it is an acute pain. And it needs to be individualized and tailored to the patient. It's not that if I give a epidural to a thoracotomy patient, the same epidural, if I put in another patient, it will work out for him. It may not. So he may need some other form of medication. So that's why multimodal again takes the core role. But if you look at this diagram, so pain is not just a sensory component. So it includes biopsychosocial factors as well as behavioral factors. So it is not that we have to just give pharmacological agents which just acts on the nociceptors or the interneurons or the dorsal horns or at the sensory cortex. We need to give many other medications along with it, which also take care of the anxiety of the patients, of the behavioral patterns of the patients. So nothing that can just give an NSAID and that will take care of. So it won't do that. It won't work that way. So why we need to take care of this pain? So pain is a pain. So there is a discomfort. So we need to relieve the discomfort. But now during this era of eras, okay, so this is very important. So that's why we need to take a very major role. Acute pain physician has a very major role for this eras. So what is eras? So there should be an early rehabilitation, and there should be an early discharge of this patient. And second thing is that we have to minimize the complications. So you might have encountered many complications, but the 2 complications which I stress upon and nowadays which are very important are that persistent post-operative pain, and then there is something called as a chronic post-surgical pain. We need to prevent these 2 aspects, and these are the major complications which we need to minimize or prevent. So before going to that, a simple term, something called as a preventive analgesia, courtesy to Dr. Shivakumar Singh, I have taken this slide from him. And preventive analgesia is nothing but preemptive analgesia plus multimodal analgesia. Now, there is no longer something called as preemptive. We call it as a preventive analgesia. So you give something before the surgical incision and then carry forward during the entire intraoperative period as well as the postoperative period in the form of multimodal components. So coming to cancer surgeries versus non-cancer surgeries, what exactly is the difference? Yes, there is a lot of difference between a cancer and non-cancer surgeries. Cancer surgeries not only involves taking out the tissue in which the cancer is involved, and it also involves a radical dissection of the surrounding tissue planes, lymph nodes. A lot of nerve structures need to be taken out when we are doing these cancer surgeries, as well as there are major surgeries. Third thing is that there's a lot of big incisions which are involved in this surgery. So that's why it's a bit different from the non-cancer surgeries. So that's why there has to be a lot of plan while executing this perioperative pain management. It is just not a single thing that we do, and it's not like hernia or hydrocele or an appendix. It involves a lot of planning and execution of these things. So how are we going to do that? So there are many ways in which we can do in the form of non-pharmacological management and pharmacological management. We will talk about the pharmacological. So pharmacological includes intravenous as well as your blocks. Okay, so in my pharmacological things, I have included everything. All right. So pharmacologicals are 2 things. It's an opioid based and a non-opioid based. So coming to the opioids, so everyone knows opioids. So before going to that, there's a pictorial depiction that where the pain generators are there. So there are various places where the pain can be targeted, and we can give an antidromic effect. So we can directly target at the peripheral nociceptors where the trauma has taken place in the form of giving NSAIDs or in the form of giving infiltrations of local anesthetics, or we can target the dorsal horns by giving neuraxial local anesthetics or neuraxial opioids or alpha-2 agonists, or the systemic opioids which do act at the opioid receptors which are present at the substance gelatinosa as well as in the periaqueductal gray matter, that is bag of the midbrain. Or we can directly target the sensory cortex. So these are the various places where we can target. Coming to the opioids, so everyone knows they act at the opioid mu receptor. So everyone knows that it's a mu receptor. But what happens at the mu receptors? There are mu receptors are present at two places. There's a presynaptic as well as the postsynaptic. What happens at the presynaptic is that it leads to inhibition of the calcium influx. So when there's a calcium influx is not happening, there is no release of the neurotransmitter, that is an excitatory neurotransmitter in the form of glutamate. So when there is no excitatory neurotransmitter, there is no nociception. At the postsynaptic level, what it causes is that it increases the potassium efflux. So there's a lot of potassium is lost into the synapses, and because of which there is a hyperpolarization. And when the nerves are in an hyperpolarized phase, even if the glutamate comes and acts, since they are in an hyperpolarized state, there is no further transmission or relay of the nociception. So how can we use opioids? Opioids can be used through various forms in the way of oral, intravenous, subarachnoid, and epidural, and we will be speaking about that. So parenteral opioids. Now there is a nice Cochrane review which discussed or reviewed about the patient-controlled opioid analgesia versus non-patient controlled. So non-patient controlled can be the guardian-related or parent-related or the nurse-controlled analgesia. And they selected many RCTs, and where the primary secondary outcome was the pain intensity. Almost 49 studies with 1,800 patients who were receiving PCA were analyzed. And they had seen that the participants who were receiving PCA had a lower VAS pain intensity scores compared to the nurse-controlled analgesia. And coming to the secondary outcomes, patients were more satisfied with the PCA. Why? Because the patients, if you give them an autonomy to control their own pain, they become more satisfied, and that's how we get a good satisfactory score. If you use epidural opioids, again, a Cochrane review shows that 15 trials have been analyzed from 1987 to 2009 with almost 1,500 participants, and they had seen that it decreases the postoperative pain as well as the length of stay in the ICU, but there is no difference in the death rate, because this is a Cochrane review which has analyzed about the abdominal aortic surgeries. I could not get a Cochrane review of our thoracic as well as abdominal, but we can call this abdominal aortic surgery as an abdominal surgery. Also, if we compare IV opioids with the epidural local anesthetics, the epidural local anesthetics take a good outcome because they decrease the post-operative IES so that the patient can have a good recovery and can be immediately discharged, what we do nowadays in the NERAS protocol. Also, the intensity of the pain during the first 3 post-operative days was significantly lower at rest as well as during cough and during mobilization in the patients who were receiving thoracic epidural analgesia. Okay, so this is the abdominal surgeries. We can call it as a lower abdominal surgeries. So why epidurals? So you see the thorax and the abdominal surgeries, usually the thoracotomies, the posterolateral thoracotomies, a lot of muscle is cut, the ribs are retracted, sometimes the ribs are too cut at the 5th intercostal or the 7th intercostal space. There's a lot of nerve handling because of that retraction. The intercostal nerves are damaged a lot. And they either do a lobectomies or an immunectomies, and if you do an immunectomies, we really need a pain-free rehabilitation process because the patient needs to undergo an intensive physiotherapy so that there is no collapse of the uninjured lung, and the recovery has to be smooth. So there was in 2005 in anesthesiology, there was a meta-analysis of epidural infusions, epidural analgesia versus the intravenous PCS with opioids, and they had confirmed that, and they had come out with the conclusion that this gives a better analgesia and a better post-operative outcome. That is the thoracic epidural analgesia. So that's why epidurals, wherever possible, you have to put. And if there are contraindications, or if you are not able to put, then you can go for something called as paravertebral blocks. And if at all, even if you're not able to do a paravertebral block, then you can go for an IV PCA. Coming to the paravertebral block versus, I will come to that. Before going to that, one simple briefing on this pictorial depiction, which has come in 2011 Anesthesiology Journal, and they say that it is just about thoracic epidurals. So whatever you do, whether it is an upper abdominal surgery, thoracic surgery, or a lower abdominal surgery, please put a thoracic epidural, don't put a lumbar epidural. During our trainings way back in 2000s, we were taught to put only lumbar epidurals, but now it is out, it is only thoracic epidurals. So if it is a thoracic surgery, you put it from T4 to T7, upper abdominal, T7 to T9. If it is lower abdominal, T9 to T12. If it is a lower limb surgeries, then you can think of the lumbar. Otherwise, lumbars are out. Yeah, so this is what I was talking about, paravertebral block versus the thoracic epidural. And now is a nice Cochrane review which has come very recently, I think in 2019 or 18. And they have reviewed 14 studies with almost 700 participants who are undergoing thoracotomy. And they found that paravertebral blocks are as effective as the thoracic epidural block in controlling the acute pain. And also, there is no difference in 30-day mortality. There are no major complications or length of hospital stay. So, if you ask me, and my personal opinion, because thoracic epidural causes a bilateral block, there are more chances of hypotension with this block. If you ask me, if given a choice, the paravertebral block should be implemented. That's my personal opinion. Even the paper also says that the two techniques are equivocal with respect to the analgesic efficacy as well as the major and minor complications. Coming to intrathecal morphine, so now there is a lot of talk about using intrathecal morphine nowadays. So even we have used in a few cases, and what is that if you give intrathecal morphine, it usually acts for about 18 hours to 24 hours, one single shot of intrathecal morphine. So they have analyzed this meta-analysis in the patients who underwent open hepatopancreatobiliary surgeries, and 11 trials were analyzed. And they had seen that the primary outcome of pain scores at rest and movement at 24 hours was very well controlled with intrathecal morphines. These intrathecal morphines also received IV PCA morphine, and this group they compared with only IV PCA morphine, and they had seen that even the consumption of morphine was less in this intrathecal group. Only one major difference they observed was that there was more pruritus with the intrathecal morphine group compared to the IV morphine group. Coming to the non-opioid based, so the non-opioid based, the major component or the major drug which we use is paracetamol, or also called as acetaminophen. And if you see paracetamol, it indirectly activates the cannabinoid receptors. Okay, so how does it activate the cannabinoid receptors? Is that the primary acetaminophen is conjugated in the liver to form arachidonyl phenolamide. So this is an endogenous cannabinoid. So what happens is that it goes and acts at the TRPV1 receptors. There is a transient receptor protein vanilloid receptors 1. So there are many receptors, TRPV1, TRPV2, 7. So this is the TRPV1 receptors. It acts as an agonist at those receptors, and because of this, there is an inhibition of the cellular anandamide uptake, which increases the levels of cannabinoids. So this is how it acts, indirectly activates the cannabinoid receptors. Also, it acts by the way of the NSAIDs, which acts at the prostaglandin synthesis. But this doesn't act at the peripheral levels. This acts in the areas of brain where there is a high concentration of fatty acid amide hydrolase. So in that areas it acts. So it doesn't act. That's why it is not an NSAID, though we call it's not called as an NSAID. So it has dual effect, both direct analgesic effect and modulation effect in the form of the cannabinoid indirect activation of the cannabinoid receptors. So there is the this Cochrane analysis, and they had found that if you give even a single shot of IV paracetamol, it gives a profound analgesia in almost 40% of the patients for up to 4 hours. So if you ask, and the literature says that 1 gram of paracetamol in an adult patient of 50 kgs to 70 kgs given every 6 hourly is an ideal dose to give a good analgesia. But if you see, there are a lot of 12 fixed dose combination of paracetamol which are available, because if you use a fixed dose combination, it gives a better analgesia than a single dose combination. And there are many fixed dose combinations which are available. The most common is the tramadol paracetamol combination, that is 37.5 to 325 milligrams, which is a common used and available as Ultraset over the market. Coming to NSAIDs, I'm not going into the mechanism of that, but you have to weigh the risks whenever you are using this NSAIDs, non-selective NSAIDs versus COXIPs, as well as in this major surgeries, because this thoracotomies and major upper abdominal surgeries, what happens is that there is a lot of blood loss. So if there's a lot of blood loss, if you see this NSAIDs, they have a potential to cause nephrotoxicities by acting at the efferent arterioles. So what happens is that if there is an hypotension or if there is a hypovolemia in this already patients who are having this major surgery, and if you give this medications, it may potentiate the damage or it potentiates the damage to the kidney. So you have to be very careful when you are selecting this form of medication. But if you see, the NSAIDs are very good analgesics because they are the best anti-inflammatory agents, and they give a good pain relief. So there is this one Cochrane review which has come as a single dose of intravenous diclofenac for postoperative pain in adults, where they have reviewed 8 RCTs involving almost 1,800 patients. And they had seen that postoperative administration of intravenous diclofenac offers a good pain relief for majority of the patients. But you have to be very careful in selecting these patients because our major cancer surgeries, there is the thoracotomies and Whipples, for example, or hepatectomies, or a major CRS hypec surgeries. There's a lot of fluid shifts. So we have to be very careful when we are administering this medication or selecting this medication. Coming to adjuvants, there are many adjuvants which are available for us to be used, and the commonest one which we are well aware of is NMDA receptor blocker, that is ketamine, as well as magnesium sulfate, which is a NMDA receptor blockade. And if you see this NMDA receptor, what happens is that when this NMDA receptor is activated, there's an activation there's an influx of calcium, and because there's an influx of calcium into the nerve endings, there's a central sensitization, hyperalgesia, and allodynia. And because of this, there's an increased sensitivity of the nerve fibers, and there is the increased relay of pain transmission. So when we give these NMDA blockers, so this central hypersensitization of the nerves is decreased. So that's why these drugs give a good analgesic effects. But if you see the difference between ketamine and magnesium sulfate, the magnesium sulfate directly acts at the NMDA receptors, where the ketamine acts at the PCP receptors. So that's the only difference. So there was one Cochrane review which evaluated the efficacy and safety of perioperative intravenous ketamine in the treatment or prevention of acute pain following general anesthesia, and where they had studied 130 studies, almost 8,000 patients, and they had seen that ketamine reduced the postoperative opioid consumption over 24 hours by 8 milligrams of morphine equivalents, as well as the ketamine reduced pain at rest at 24 hours by almost 5 by 100 mm on a visual analog scale. So perioperative intravenous ketamine probably reduces postoperative analgesic consumption as well as pain intensity. So there were many studies, almost 130 studies. These results were very inconsistent. There is another review article which studied about the perioperative intravenous administration of magnesium sulfate and postoperative pain, and it's a meta-analysis. And they had said that intraoperative magnesium improves the postoperative pain. However, we need to do, there is no good evidence because of the inconsistencies in the studies which they had reviewed, and they had asked for better randomized control trials. Coming to lignocaine. So lignocaine, how does lignocaine act? So if you give lignocaine infusions, so what happens is that because of the tissue injury, the neutrophils are degranulated, and because of the degranulation, there is an amplification of the inflammatory response. So what this lignocaine does is that it down-regulates the neutrophil degranulation, and because of the down-regulation of the neutrophil degranulation, there is a decreased or de-amplification of the inflammatory response, and this is how lignocaine acts. And again, this Cochrane review which has assessed the benefits of the perioperative IV lidocaine infusions, which included 68 trials. They had given a very uncertainty whether it really helps or not. Coming to tramadol, these are the centrally acting synthetic analgesic agents, and mainly the metabolite desmethyl tramadol has a mu-opioid activity. So this is how it acts on the opioid receptors, as well as it has a dual action of acting on the norepinephrine and serotonin receptors. So where it all inhibits the reuptake of this norepinephrine and serotonin. It should be avoided in patients with seizures, and it should not be combined with SSRIs. That is what they say, because of the serotonergic reactions when we are using this. And the daily doses of 400 milligrams is the maximum dose which can be used in healthy adults. Tapentadol, again, it acts like tramadol. It is a centrally acting oral analgesic drug. It acts at the mu receptors, same action like at the norepinephrine level. So the only advantage of tapentadol over tramadol is that it has inactive metabolics, and also it has no effect on serotonin reuptake, so it can be safely used with SSRIs. Coming to gabapentinoids, there was a lot of work which was going about the use of gabapentinoids preoperatively over the last decade. From 2011 to 2019, there was a lot of work which went around, and in anesthesiology, there was a nice systematic review and meta-analysis which has come up in 2020 anesthesiology about the perioperative use of gabapentinoids and management of postoperative acute pain. And they had included 281 trials, almost 25,000 patients, and what they had said is that when they had compared these gabapentinoids controls, no clinically meaningful difference in acute, subacute, or chronic pain was observed. So it is of no use. So we still use it in our thoracotomy patients, but now after these articles, we have started questioning our usage of gabapentinoids in our group of patients. I won't be going about this. Coming to the facial pain blocks, now there is a nice article which has come. There are many facial pain blocks. Suppose in cases where you are not able to put an epidural, or in cases if you put an epidural, the epidural is not working, you can use these facial pain blocks as rescue blocks. Especially if there is an upper abdominal surgery or a lower abdominal surgery, you can use the tab block, the 4-quadrant tab block in the form of subcostal, bilateral subcostals, as well as lower tab blocks, or you can use a rectus sheath block, or you can use an erector spinaplane block, or you can use a quadratus lumborum block, anything in whichever technique you are feasible, or whichever dermatomes you want to block. Based on that, you can use these blocks. And there's a nice meta-analysis which has come recently in 2020, and they say that it's an erector spinaplane block is an effective strategy to improve the post-surgical analgesia. But there is another meta-analysis which has come in breast surgeries, because the erector spinaplane block is mostly used in breast surgeries. And they have said that since there are inconsistent studies, they are not recommending it, the erector spinaplane block as a sole analgesic agent while conducting the breast surgeries. Coming to the tab block, again, this review says that it plays an important role in the management of pain for up to 24 hours, because this meta-analysis, most of the studies were the single shot tab blocks rather than the continuous tab blocks. Coming to the wound infiltration, yes, wound infiltration also plays a major role, and this study has analyzed that because most of the studies have been done where they use the post-incisional infiltration. When you use a post-incisional infiltration, they don't have a good relief. But if you use a pre-incisional infiltration, yes, it does give a good amount of analgesia. Okay. So overall, if you see, the multimodal analgesia is based on paracetamol, where there are pillars of NSAIDs, NSAIDs, coxibs, opioids, tramadol, ketamine, gabapentinoids, lignocaine, alpha-2 agonists, covered with our local anesthetic. So it is a must that you should use paracetamol in all patients, covered by a good local anesthetics, and you can use either of these. Don't use all of this, but either of the pillars, according to the indications and contraindications of the patient. So how will you execute your perioperative pain management? So you have to first know the expectations of the patient. So whenever you go for a preoperative round, what we do is that we usually carry our kit. So we carry our disposable infusion balloon pump, epidural set, we carry our pain scale, and we explain to the patient what exactly is the pain scale, how you have to interpret the pain scale, what pain you are expecting. We have to educate the patient, because we tell them that suppose you are underwent a thoracotomy, you need to do an intensive physiotherapy. So you need to do cough, and when you cough, there pain is bound to happen. We tell them that the pain is bound to happen. We don't give them a false hope that there won't be any pain. Pain is bound to happen, and we are there to get down that pain. So it's not that we will make it zero, but we will make it to a comfortable level. Okay, we provide proper instructions to the patients how to use this pain scale, because most of the patients, when they see a doctor, they always say it is 10 out of 10. So we always, because there is an abstract thinking, so we have to tell the patient that if you tell 10 out of 10, our role of pharmacology management differs from what exactly is your pain. So then you may have more side effects if because you are having a pain 3 and you are telling me that the pain is 10, and we try to give bombard you with more opioids, or we are bombarded with interventions. So we educate these patients, and we give a clear-cut communication, and we plan a proper perioperative pain management by discussing with our surgeons, especially in thoracotomies and bone soft tissue patients. So this is what we do. You see, this is me. We are taking a pain drone. We have a pain nurse, and this is our this thing. We are online based system, so we carry our tab at all our places, which is connected through Wi-Fi, and this is our online post-operative pain management medical record, where we enter the details of the patients. We also have still using the paper format in the we call it an yellow form, and we have designated acute pain service protocols in our hospitals. So coming to this thorax and major abdominal surgery, so this is what Dr. Raval, I think Narinder Raval from Sweden, I suggested that paracetamol has to be used with epidural, local anesthetic, or plus opioid combination. Most of the times our opioid combination is in the form of fentanyl, and for thoracic and upper abdominals, mainly for thoracic surgeries, we use 5 micrograms per ml of fentanyl, whereas for upper abdominal surgeries, we use 2 micrograms per ml of fentanyl. And now there is something called as prospect protocols. There's a procedure-specific pain management protocols, and if you see here, if the patient is undergoing a thoracotomy and if epidural analgesia or paravertebral blocks are contraindicated, you can directly go for IVPC, a strong opioid. If it is not contraindicated, you can either go for thoracic or paravertebral. Either may be used, but even this procedure-specific pain management protocol emphasizes the use of PVB, that is the paravertebral block, and you can use a local anesthetic plus opioid combination in the form of continuous infusions plus NSAIDs or paracetamol if these are contraindicated. NSAID in our protocol, what we do is that for the first 24 hours, if it is not contraindicated, all patients get NSAID for the first 24 hours. And later on, the acute pain service consultant takes the call whether it needs to be continued or not. So this is how we manage. Thank you very much.
Raghu, for your time and for sharing us with your knowledge and all your experience in treating the pain syndromes.
Can we have all on the screen? Can we have all the speakers on the screen, please? There are a few questions that has to be answered.
So now the floor will be open to discussion for questions and answers which we received from the audience. So, I mean, I would like to start with, no matter how many ERAS protocols are there, and, how much we see this opioid addiction and opioid crisis, and how much we try to minimize the opioid usage in order to decrease the addiction or the side effects of the opioids, and move towards more of an interventional nerve blocks or newer modalities which can help us in decreasing the opioid consumption. But as we see from the last few presentations that we still see that opioids stay the main treatment, a main gold standard for outpatient, cancer-related pain treatments. So I guess in this regard, I would like to add something. Recently in October 2020, there is a new opioid called oliceridine, which was FDA approved with minimum respiratory and with minimum GI side effects, which was brought into the market. And I was just wondering if you guys heard about it, any experience in UK or Singapore or any of your places. Was there any discussion regarding this new opioid in the market? Do you
So,
think that will
if I
replace the
can-
morphine which we are using as a gold standard?
So I must say that I did hear about Olesarin, but in NHS it is not used.
It's not useful?
It's not available to be used in NHS.
Okay,
Not available.
I'm sorry.
Not available in NHS.
Not available, yes, yes. Because, I mean, the way they were marketing is that, you know, it has more of affinity towards mu receptors, partially it very biased to the mu receptors, which decreases the side effects of respiratory and GI side effects. And
So-
when compared to the morphine, it has 400-fold affinity to mu receptors, which decreases those side effects. And also, it's only hepatic clearance. It's not impaired by any renal dysfunction or anything. So, I mean, the way they are marketing it seems more promising. But as you said, when it's available and as and when we start using it, probably we get to know more about it. And moving on to the next, I'm sorry.
So I agree with what you said, that Olesarin has been in the journals also these days. Having said that, NHS, they will not approve unless the studies prove that it is more effective, because ultimately NHS is free service, so it has to be, I mean, there have to be some solid evidence. Same happened about the combination of OxyContin and naloxone, oral one, Targit. That also never reached NHS, although they were super heavily marketing. That happened in actually 2009. So it's not available in NHS yet.
So I guess we'll wait and see what happens in that opioid world then.
Yeah.
Moving on to
Yeah,
next.
there's one question from one of the viewer is basic question. Explain the different types of cancer pains. Anybody? Any type, different types of pain, basic.
There are many types of cancer pain. Basically, because of the cancer itself, there is a pain. There's a cancer treatment related pain, and there is something called as non-cancer related. The cancer patients do present with non-cancer pains, but the major chunk of the patients who present to us are the cancer related pain, mainly because of the cancer itself. So it can be in the form of the soft tissue, or it can be in the form of the viscera, or it can be in the form of musculoskeletal system like bone metastasis. Cancer treatment related, mainly the surgical things, even the non-surgicals in the form of chemotherapy and the induced mucositis, chemotherapy induced peripheral neuropathies, and non-cancer pain can be anything.
So Dr. Nadir, I guess that answered your question. And moving on to the next question, I guess this is related to Dr. Sandeep's topic, the role of intrathecal baclofen. I mean, as we all know that FDA has approved only 3 drugs to be administered intrathecally: baclofen, morphine, and ziconotide. But more and more, you know, you see more of these baclofen pumps being installed, implanted in the back. It's a interventional procedure also. You know, it takes some time financially and, interventional wise also. But still, you know, we see that more and more of these patients, you know, with the kind of knowledge that we have, they are benefiting from IT baclofen. So in your experience, if you can share with us the usage and the side effects, and how do we maintain the intrathecal baclofen pumps?
Is it for me?
Dr.
Yes.
Sandeep, yes.
Okay. So in first and foremost, the maintaining any pump is not easy. You have to have a team, like practically you have to have an on-call person, and that does happen in the specialized pain clinics. Same true with just specifically baclofen. Now, baclofen is mainly used for spastic disorders. So mainly the patients will come from neurologists or discipline will be from neurology. So most of the time, this is worked with the neurologist, and as anesthetists, we try to escape. Having said that, we do put the pump in, and we have a team. Intrathecal baclofen is very much licensed for spastic disorders. Usually, the dose you start with around 50 to 100 microgram as a bolus dose, and then maintain they require around 2 to 400 microgram per day. The pump has to be reviewed every week, and it's auto refillable. Obviously, the nurse fills it. At any slight indication of sepsis, which can be in the form of local induration, or local erythema or slight fever has to be immediately treated. I have seen only one. It was not intrathecal baclofen. It was actually it was just morphine. One severe, epidural abscess I've seen. Actually, it was diagnosed quite early, and the patient didn't have long-term problems. It's not an easy service to maintain.
Thank you, Dr. Sandeep, and would like to end this webinar today with one last highly controversial topic with the regional anesthesia in related to, I think more of the research has been done in breast cancer surgeries. There are few articles that say that, it helps, the regional anesthesia when compared to the general anesthesia will help in reducing the recurrence, and some say that it actually causes the recurrence. So just share your knowledge and experience on that, whether pro and cons of this when it comes to especially the breast cancer surgeries.
For me?
Anybody?
Anyone?
Yeah, so basically, yes, you are right. A lot of studies have been done on the local anesthetics, and especially in the breast surgeries. Even one of the study we have conducted in our institute too, our breast oncosurgeons. And what happens is that this local anesthetics, what happens, what they do is that they decrease the antigen presentation of these tumor cells. Also, they activate the natural killer cells. So because of these two major regions, because the natural killer cells are the cells which attack the metastatic circulating tumor cells. The regional anesthesia, so the local anesthetics which we are injecting into the blocks, either in the facial planes or directly over the nose. The studies have said that they do prevent the survival, disease-free survival, they increase the duration.
Thank you, Dr. Raghu.
Yeah. Thank you, Dr. Sudhir, Dr. Raghu, Dr. Sandeep, Dr. Santosh, for your participation in today's webinar at a very short notice. And it's a privilege, in fact, to have you all in today's webinar. No more questions from the audience, but if any question comes, I'll keep this group which we have made live for one more day so that we can post the pictures also. And I'd like to conclude this session by thanking again each one of you. I would like to thank Dr. Jivira, who is the head of the Department of Surgical Oncology and Surgical Gastroenterology and Minimal Invasive Surgery, for giving us this platform to conduct this webinar. I thank our IT and audiovisual team, Mr. Mohan, Mr. Satyanarayana, and Mr. Robin and his team for this excellent audiovisual backup, and each one of you. And all the delegates, of course, without whom the webinar is incomplete. So thank you each one of you, and have a lovely evening. Any questions, I'll keep in this group so that we can get back to the viewers. Thank you very much.